Um, a lot of my work these days is on AI and machine learning in digital health. All of the things that Marek described, I still do. But I'm a member of a number of leadership organizations about implementation of digital techniques in mental health context. And so today, I wanted to be able to give you a description of what I think the future will be, which is something that a lot of people will resist, but something that has a lot of potential for improving healthcare for many people in physical and mental health. So as a Canadian, it's our tradition to give a land acknowledgement. I live in Bear Hills territory. This is actually one of my neighbors who lives to the west of me. It's the traditional territory of Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene and Ojibwe, Saulteaux, Anishinaabe nations, known as the people of Treaties 6, 7, and 8, and a homeland of the Métis people. My affiliations: I'm also now leading Mental Health Research Canada, scientific director of the APEC Digital Hub for Best Practice in Mental Health, and on the E-Mental Health International Collaborative. It's a big international think tank for digital health. And I'm on the advisory board for managing the Alberta Machine Intelligence Institute. I have no conflicts of interest there. Because people are often left at the end of talks, I want to just talk about some of the people I work with. All of the work that I do is collaborative with other people. They're all wonderful people and super important. The person highlighted in yellow is actually Seta Modanlo. If you could stand up, Seta, for a second. Seta is one of our PhD students and is here at this conference for the first time. So please ask her whatever difficult questions you can find. It's a wonderful group of computing science people, psychiatrists, psychologists, nurses, and health policy people. I want to start by talking about how prominent the University of Alberta is for machine learning. We're one of the top 3 global sites in the world for AI and machine learning technology. And one of the things that signaled that is that DeepMind, a very prominent machine learning entity, opened their first other office in Edmonton with the Alberta Machine Intelligence Institute. And I wanted to start by talking about the power of machine learning and the power of AI. And the best way to do that is to talk about something that happened back in 2017. DeepMind created a solution for the game of Go. The ancient Asian game of Go is very difficult, very complex, and computing scientists like to get machines to beat people. You always remember the chess days when IBM and others were making big attempts to beat human players. Well, AlphaGo is an algorithm that used machine learning to defeat the world champion player of Go. Everybody was very impressed that this algorithm was effective. And the reinforcement learning basis of this was something that was actually established, by Rich Sutton, who is one of the professors in computing science at the University of Alberta. So after AlphaGo was born, they came out with something called AlphaGo Zero. AlphaGo Zero is so important because here is a computer entity, a machine learning and neural network combination that was given no instructions. The data set was presented to the AI entity, and it played against itself until it learned the game of Go more effectively than anything it had ever done before. A paper came out in Nature in 2017 describing this, and AlphaGo Zero was a real leap forward in what machine learning and AI could do. If you look at the diagram on the right-hand side, in 40 days, with no instructions, playing with itself, AlphaGo Zero beat all of the champions in the world and beat AlphaGo. This was the beginning of a real leap in the ability of AI. And now there is no limit to what artificial intelligence can do, potentially. In health, we have some problems. We know this. Well, the Economic Forum report, G7 comment, was about, despite our efforts, recovery rates in mental health are not as high as we believe they could be or should be, because there'll never be enough trained therapists to meet growing demand. We need to radically scale up care, use automation and augmentation to make scarce clinical resources go further and democratize access to quality mental health care. In every part of the world that I know, people do not have adequate access to mental health care, and mental health is the biggest health burden. Everybody is aware of what I call the new kid on the block. Generative AI is something that drives large language models, chatbots, ChatGPT, and so on. I picked Gen BI not because I support the company, because this represents the kind of interaction that computing science has with many areas. Gen BI, working with a lot of leading industry partners, will handle any request with access to data. It generates solutions very rapidly, much faster than anybody could do in human terms, and it is claimed to be secure and well-governed. This is now commonplace. If you look at a search engine like Bing, it has something on the side that will write a description of what you're searching for and provide a summary. At the great universities of the world, I'm sure in Turkey as well as places like Harvard, undergraduate students have been getting this stuff to write their papers and have them marked and do very well. And universities are fighting back, trying to discover whether they use generative AI. So there's a huge amount of power behind AI these days. This started with GPT-4. I'm not going to go into this detail. And if you want OpenAI and you want to have a look, you can go on the internet and look at GPT-4. We have a computational psychiatry group, and our work is quite broad. We focus on a number of illnesses, the major psychiatric disorders, some neurological disorders. The data we use includes genetics, imaging data, neuropsychological assessment, natural language processing from human speech, and health records. I don't have much to say that's good about health records, but we do deal with health records. We've looked at clinical trial data from industry and from archives provided by agencies like National Institute for Mental Health. And we're interested in chatbot development. Chatbot development is super important because if you are going to talk to a computer with generative AI, large language models, that computer has to understand what you're saying, and it has to give an appropriate answer that you can understand, that has to be accurate and safe. So that is a very important part of development. Our goals are diagnosis, prognosis, clinical tools, and more recently, streaming data analytics. Streaming data is something I want you to pay attention to because I really think this is the future. We have published a lot of papers. There are some examples here. They deal with all kinds of science things and health data analysis things. I'll talk about some of them. They range across a whole range of disorders and looking at neuroanatomical things, drug responses in a variety of contexts. AI is based on predicting a signal from noise. This is a receiver-operator characteristic curve, set of curves that we use basically in machine learning. And the closer the curve is to the top left-hand corner, the more accurate the decision is. What can AI do in the health data context? I'll tell you quite simply, and I've not been told by people who are much more expert than I am that I'm wrong, so I think this is correct, that AI will do two things. It will distinguish between categories or labels. Is this A, B, or C? Is this bipolar disorder, schizophrenia? Is this mania of a particular kind? State change. Will this manic episode turn into bipolar disorder? Will this person with depression, given this drug, go into remission? The two functions of distinguishing between categories and predicting change of state, multiplied and combined, are essentially the tools we use to discover everything. And these are the two things that AI will do. And so the limits now, with the power of the algorithms we have, is unknown. Examples. looking at multiple brain parcellation from neuroimaging using ensemble learning to predict schizophrenia and predict responses. Individualized identification of bipolar disorder first episode, so early identification using machine learning and cognitive tests in a way that can't be done by people and their brains. Detecting the presence of PTSD using sentiment analysis from text data. Machines don't really distinguish between text and speech. They'll do two kinds of analysis. They'll analyze the text content of language, or they'll analyze what language sounds like, the intonation, and so on. In this case, it was from text data, transcriptions of interviews. The team involved put together a superlearner final. There was a random forest model that was making the decisions. And here we have actually a database that was created out of serving military members who are being interviewed by Ellie, which is actually a machine learning avatar. It was an artificial interviewer to make things more confidential. And you can see the difference between the green and the blue histogram bars there shows a difference that you can see that was highly significant for deciding whether somebody had PTSD or not from their speech alone. Predicting pediatric anxiety from the temporal pole of the cortex. This was an interesting study that was done with fearful and angry faces, looking at a whole range of children that were anxious or non-anxious, and seeing if the machine learning solution could discriminate between these two groups, and seeing which features of brain were most highly predictive. And this study pulled out the temporal lobe of the cortex based on the Talarak regional description of brain areas. This area had never been looked at in child anxiety before, so here machine learning is revealing part of a brain structure that may be a good target for analyzing the basis of childhood anxiety. We've also used large data sets, including international collaborations with colleagues from other countries, including China. Here there are two data studies, one using the Canadian National Longitudinal Study on Aging cohort to predict depression onset among middle-aged and elderly adults, just using machine learning and a lot of labels. And the other is individualized prediction of who is going to get opioid use disorder from health data from the Alberta health environment. Prediction of who's going to respond well to an antidepressant drug is super important. So many people have depression, so many people are on antidepressants. Unfortunately, healthcare professionals do not do well at this. Meta-analysis has revealed that 37% of patients don't achieve a positive response. 53% do not achieve remission following 6 to 12 weeks of a new antidepressant. We looked at Pfizer clinical trial data, and our machine learning analysis was able to predict with a 69% accuracy who would respond to desvenlafaxine. So using a machine learning solution, you can get a higher performance than deciding as a psychiatrist or psychologist in the US which drug to give to which patient. And people always say 69%, that's not really good. It's a machine, it should be 100%, but it's a lot better than humans do. And that's the point. As a patient, I would take 69% over 37% of patients don't achieve a response at all, and 53% don't reach remission. One of the issues here is that the features that machine learning pulls up are quite bizarre sometimes. I don't want to go into too much detail here, but our algorithm identified 26 features. This was an international set of clinical trials. 9 country of origin labels were predictive. Not surprisingly, perhaps, if you're indigenous United States citizen or in mainland or in Alaska, well, we know indigenous people have higher risk, but this was predictive features for a response. 8 items on Hamilton Depression Scale, 3 items on the MADRS scale, 1 measure of polypharmacy that includes the pill count that you have, including supplements and non-prescription drugs. Nobody would look at that. And then 4 lab tests that didn't seem to have anything to do with mental health. That was the basis of this machine learning prediction, just looking at all the data we gave. So where's this all going? I'm giving you these random examples. The message I want you to understand is there is an AI-centered revolution that's taking place. It will change the world of medical practice, likely beyond our current imagination. Multi-trillion-dollar future for generative AI technology in health. World Economic Forum, based on a McKinsey report, says generative AI could add trillions of dollars in value to the global economy, and then talks about global healthcare systems under more pressure. If you think we cannot change because we don't want to, faced with industry and commerce thinking about a multi-trillion-dollar increase in activity, that is a tsunami that is coming that you will not be able to get in the way of. So better to make the right decisions and work proactively with AI than to not want to do it. Clearly, if it's done properly, it will be done in a way that works for people, not just having people railroaded in. And there's a reason for that, because for AI to work in digital health, people have to engage and want to do it. You can't simply impose it on populations. There's a book that a lot of people don't like. It's from 2015 by Eric Topol, who's a cardiologist working at Scripps back in those days. The Patient Will See You Now. And this was a prophetic book talking about the digital revolution and how there'd be a democratization because people would be able to see their own health measures, go on the internet and understand what it means because they could ask in an equitable way. They didn't need access to a physician to explain it to them. And this is what Bing, the generative AI search engine, says, thought-provoking. If you're interested in the intersection of technology and healthcare, this book is definitely worth a read. It's out of date now, but a lot of the things that were proposed are actually happening. And if you watch television in the United States, you will see companies putting advertisements where, strangely, the doctors are in the waiting room and the nurse comes and says, "Excuse me, Dr. Smith, your patient will see you now," turning everything upside down. Several questions are prominent in digital health, and these apply to healthcare in general. They haven't been asked before because of the way the system has been built politically. It's quite patriarchal. But the rise of digital health has pushed them forward because everybody has a voice. And now, the common wisdom that's emerging and being endorsed by states is that finding solutions that are best for patients and include the patient's living perspective is the way we should do things. This is leading to co-creation of health solutions with patients. There are many places where you see health quality indicators. I like this one, it's close to home, it's the Alberta Health Quality Council. And if you look at the top line here, you'll see terms that describe dimensions of quality. Acceptability, accessibility, appropriateness, effectiveness, efficiency, and safety. These apply to traditional medicine. But if you're going to roll out a digital health solution, it has to be acceptable. If an app or a device is not acceptable, people won't use it. It has to be accessible. Well, we know the health system is not very accessible, but digital techniques may enable a lot more accessibility. Appropriateness. Is it culturally appropriate? Is it equitable? A lot of healthcare offerings, by virtue of the way the health system is built, are not equitable. Vulnerable populations have differential access to healthcare. If you're a member of a minority ethnic group, religious group, cultural group, quite difficult to access mainstream health services. Is it effective? In many health systems, there are no health outcome measures. In North America, outside private industry, health outcome measures are not good. I talk to research psychiatrists in Canada that I work with. We do research together. We use health outcome measures. And I say, so what do you measure in your office? And they look at me and they kind of look awkward because they don't actually measure anything. It's their opinion that counts, and they navigate how they feel. Even though they're trained and they know there are specific measures, it's not typically done in a private office or even a hospital clinic. Hospital outcome measures in mental health are very, very poor. So how do you know something's effective if you don't measure outcomes? Is it efficient? We know there are lots of inefficiencies. And is it safe? Safety is a thing that pops up with digital health because everybody worries, will the machine get it right? Will the information be accurate? Will it be correct? It's the same with human things. So to meet patient and client needs, here we have on the left accessibility, acceptability, appropriateness, effectiveness, efficiency, and safety, all of which require access to useful data at the individual patient level. Nobody wants to know what the average patient does. I don't want to be based on the average or typical patient. I want to be based on my patient data because I am an individual case to be treated. The average, one could argue, is a very rare thing. We need capacity to collect, analyze, and store appropriate data. The electronic health record is not very good, and we don't have easy means to do it at the moment, and there are issues of privacy and security. We need streaming data capacity. Existing health admin data are not adequate. Typically, if you try and get access to health data and you're not a professional with access, it's very hard to get into the system, even if you're a research scientist. And when you do get access, the data are 2 years old, and I just told you they don't have outcome measures. So it's tough. Everybody wants access to health data until they get access. What about digital health today? I leave here to go to Australia and New Zealand for strategic government meetings about digital health. Australia and New Zealand are the leaders in digital health in the world. Their main efforts are still telemedicine. In New Zealand, there is Whakarangaroa, that is a digital health entity full of people on telephones. They're still phoning people on a helpline. The world is still in telemedicine. Since we moved into COVID 2019, we shifted into video using platforms like encrypted Zoom, and that's become more commonplace. We did it because we had to, not because we wanted to. And questions arise about safety in the context of mental health. So working with my colleagues who are interested in trauma-informed care, particularly Lisa Burback and her group, we have done work on, is web-based psychotherapy for mental disorders effective and safe? We did a scoping review to see if anybody had measured that. Standard Prisma approach to doing this, from 13,000 publications, 48 articles survived the screen. Most studies measured treatment effectiveness and acceptability, and they're comparing cognitive or exposure intervention for PTSD, mood, or anxiety disorder. Generally, face-to-face and web-based therapy are equivalent. It's very effective. Safety wasn't measured in many studies at all, and treatment accessibility, appropriateness, and efficiency were not measured. These are mentioned as the future. We published this in 2023. The work has not been done. We did a randomized controlled trial looking at web-based EMDR, eye movement desensitization reprocessing, for adults with suicidal ideation. Only people with suicidal ideation were included. Why? Because people worry, if you have somebody on Zoom, can you treat a suicidal person without being in the same room? Actually, when they have a person that's going to assist or a help link, it works pretty well. I'm focusing on adverse events. Actually, the EMDR group did much better than the treatment as usual group, but nobody committed suicide. One suicide attempt in the EMDR video group. Treatment as usual group, more suicide attempts. Emergency room visits, accident emergency visits. Treatment as usual group did not do as well as the EMDR group. And none of the EMDR group were hospitalized. So looking at Zoom treatment as usual or EMDR with suicidal patients, preliminary data shows the risk is quite low. A lot of people would like to do it this way rather than attend an office because of their trauma histories. So this is useful research, but we need a lot more of it. Everybody wants to get into electronic health medical records, EMHR systems. They're not really informative for health analysis. Consider diagnostic codes. In many places, in North America, we use DSM, in Europe, ICD. What code do people put down in their histories and notes? Well, they typically use the most general code so they don't have to think too carefully about what the diagnosis is, because it's not about treatment, it's about the record. And they may actually pay attention to which code gives them most return if it's a billing system. And for research analysis, it's difficult because you want to know what the diagnosis of the person was from a health record. You just can't tell sometimes. And the data are old when archived. Do we all think that 2-year-old data is what we need to generate health data analysis? I don't think so. It's too old. We need new data. Very few people comment on this. There's this engineering principle of garbage in, garbage out. So if you're trying to do analysis, you have fine analytic techniques. If you put in low-quality data, you get low-quality results. Joan Tino from Brown in the US and working for the RAND Corporation published a little comment in JAMA Health Forum. Medicare billing data may reflect health professionals' attempts to maximize reimbursement rather than assess the patient's disease severity. And developers must oversee the data's accuracy and how proposed rule changes on data collection could affect the prediction rule's validity. If you don't have good data, machine learning is not going to be super helpful. We have had this problem. A recent paper looking at vulnerability of children from our group in Alberta using something called the Early Development Instrument. We get a cohort of 28,952 children. We figured out what the main risk factors were. It's fairly crude, but it's objective and it's useful for policymakers. They are biological sex, poor socioeconomic status, and a history of mental diagnosis are big risk factors for children. If you look at the table, it was a very complex thing. We had lots of different administrative databases we had to amalgamate. But in the little orange label, it says the years child had mental health diagnosis. And we realized if we'd had good health records, we would have been able to distinguish the risk between children who had different mental health diagnoses, because some are surely going to signal more risk than others. The data were just not available. We've had some successes. This was prediction of the development of opioid use disorder in Alberta health data, about 4.5 million people in the whole population. Despite limitations, this diagnosis is clear in the health record. Whether you're addicted to opioids, it's relatively easy to see. So we could work with that. And we ended up with a good prediction based on analysis of about 800,000, 900,000 people. We were able to predict those who were likely to develop opioid use disorder from a historical cohort over many years. What we really need to do is to be able to do that in people today. So we have rapidly developing health systems, big potential advantages for including digital health with machine learning and AI. As part of my work with the APEC Digital Hub for Mental Health, we're building digital health for the Philippines. There's been a change in government, a reinvestment, and they want advice about what to do. And everybody from outside is saying, do not invest in an electronic health record. Try remote sensing, try do things differently. It's a bit like you wouldn't invest in landlines for telephones. You'd go to cell service immediately. Health priorities. We know we have a big global burden of health from WHO and others. There's a real need for accessible treatment and care. And the big question is, will AI and machine learning provide solutions? Online stuff is good for a lot of things, and one of the big barriers for mental health for all of us in this business is stigma and people not understanding. There are great online resources, particularly in Canada, coming from Canada, on mental health literacy, educating people at different levels about what is a mental health problem in schools for adults. This is really making a big difference and changing health parameters. Privacy is an issue. I'm not really going to go into that. Concerns in most health systems are wait times if you go to a clinic, or wait times for a referral, how quickly you'll be seen. Early identification and early intervention, we know, are effective. If your problem is identified early and you have an early intervention, it's likely that you will have a better outcome. Continuity of care is important. It's very difficult to have an assessment and then get a referral and have a month or 2 months of no treatment and just be without care. Access and equity. Some people have better access than others. Access should be equivalent for all people, and digital solutions offer that possibility. And then we come to what I call the unsung relationship of physical and mental health. If you all think about somebody, patient or somebody you know who has a physical health problem, I'd be very surprised if they didn't have any kind of mental health problem. Stress, anxiety, depression, hopelessness. And if you have someone with a mental health problem, I'd be very surprised if you didn't know something about the physical consequences of stress, anxiety, and hopelessness. I get very annoyed when people talk about mental health and addiction as separate areas. They are the same. But mental health and physical health, they're not even close cousins. They're the same thing. And there's a green space in the middle that just isn't explored. Digital health will lead us there because for most sensing of health, we have physical and mental health measures. With buy-in from clients or patients, we need that buy-in. We can have validated individual, person-level physical and mental health data, each one of us. We could have streaming data coming from a device, a smartwatch, a phone, a different kind of device. If that information was fed to the right place, we would have accurate and appropriate capacity for relevant clinical analysis. One of my colleagues is an emergency physician, and he came to me, finished a degree at Johns Hopkins. He wanted to do digital health and machine learning. And we talked about things, and he said, when I'm in emergency, whatever the person is, sometimes the person is really sick and in danger, I cannot admit them to hospital. I give them advice and they leave, and I worry if they will be okay because no one is watching. In COVID, people at home alone sometimes didn't make it because nobody was watching, and they couldn't assess their own symptoms. This is true for mental health and physical health. So having a remote sensing that is automatic, you don't even have to know your own health status to get support. Appropriate health system access to the data to support health decisions. The people that want to go to a clinic who don't know much about health, if they got feedback on their health parameters, they would know if they should be proactive and go early. They should know if they should wait and go if something happened. And they'd know if they didn't have to go. There are many people who go and access medical services. They don't need them, and it clogs the system completely. That's in every health system. We'll never have enough people to serve the needs of our patients, but we do have AI sentinel technology. And smartphone technology for physical measures and for mental health assessments is possible. The future that we talk about has actually been here for a while. This technology has been in place. This is an old chatbot from China, Tmall Genie. That was the first thing that really pushed out and showed people how robots could talk to people. We've been developing smart sensing devices using existing technology. Some people build their own. The big data giants spent trillions of dollars developing things like Apple Watches, phones, Fitbits, Android phones. We want to use those. So we want to build our technology in a device-agnostic way. Doesn't matter if you have Apple or Huawei or Android. Doesn't matter. Anything can come into this system. And by using watches and phones, we can collect data on heart rate, blood pressure, and we can do assessments with a small scale on a phone, answer 7 questions. GAD-7, answer 9 questions, PHQ-9, another scale. Answering 15 questions once every 1 or 2 weeks gives you a good mental health profile. The way we do this is someone has a watch, their data already go up into the Apple cloud for an Apple Watch. It's already stored there. We don't need permission to store the data. We don't need the storage. We get a data tag, they give us permission, and we pull their data down from the Apple cloud. We analyze it on our own private cloud platform. We take out the information we need, and we delete the data because it's already up in the, we can go and get it anytime we like. So all the privacy and confidentiality arguments disappear because you already put your data in the Apple cloud. It's nobody's problem but your own. It's your choice. That is a very democratic way of handling data. And then, the data police are not, you guys have these data. You can't hold patient data. They're not my data. I got them from the cloud. And as soon as I've analyzed them, given the information to the patient, I'm deleting the data. So our app, you grant access to the app. It will collect data from, let's say, the Apple cloud. It will do analysis in the cloud platform, and it will send the information back to you. Things like, this is a dummy example here, but what are you doing in terms of stress? What are you doing in terms of heart rate, activity? You can even have blood pressure and other things. This is what it really looks like. You have the mobile app, gateway with load balancing, scalable web service, the analysis and biomarker information, and there in the bottom is the machine learning model. That's the interesting piece, because there we have to do some clinical decision making. Looking at your baseline, is your baseline for physical health okay? Is your baseline for your mental health responses okay? And we know that some physical measurements correlate with mental health problems. Activity is a very clear one. So all kinds of possibilities. This is at the beginning of what we can do. Here's some data from 2 post-COVID patients in remote and rural areas. They're out there, there's no medical person around. We're pulling data from the Apple cloud. We're watching their heart rate. This is average data over a number of days. We're looking at how many steps. We can get their blood oxygen levels. We can get all kinds of things. There's nobody there but the machine, and the machine can inform people. In the case of someone who goes home from hospital and is very sick and they go to sleep and they start to fade, the AI Sentinel will see it and with their permission could tell the healthcare system to go and get them. That's fabulous. We can all have that. Why would anybody not want that? As far as the mental health measures go, working with my friend and colleague Vincent Ajapong, I presented some of these data before at this meeting. He has been doing supportive text messaging. And with the supportive text messaging, occasional assessments of brief scales. And the scales in this case that have been used many times are perceived stress scale, PHQ-9, and GAD-7. They give clinically validated measures of mild, moderate, and severe. And we can measure changes in health with these simple measures. It's not a psychiatrist. It's not an interview. It's not even a nurse talking to somebody. It's putting 15 items into a phone. If you're care about your mental health and you're motivated, you do that. Women are really good at this. Men are terrible at this. Responding on apps, there's a huge sex bias. We haven't had data enough to do a gender analysis, but women are the health navigators of the world. They look after their health, their family's health. They even look after the health of people outside their families. It's been studied. So testing this on women is amazing. So current system issues. There are issues of equity, ethics, and privacy. It requires democratization of health data ownership, or the system barriers will be immense. As we say in English, we dodged the bullet by going to cloud data owned by big data giants, because people have already put their data up there. We can pull it down. But if you try and make a system yourself and try and keep the data yourself, you're in electronic health record territory. Very, very difficult place internationally. User buy-in is necessary. I've talked about the patient. The physician also has to buy into this. Family members all have to buy into this. I mentioned women. A lot of women using health apps, they also see the health indicators for the rest of their families. In an Apple system, you can watch the whole family health if you're the mom in the family. Typically, that's what happens. And co-creation is necessary. If you co-create things, you deliver what people want and understand. Too many times people create something and they push it out, and a lot of apps die because people don't like and want them, even if they're good. So, coming to the end of my talk, what are the risks, challenges, and opportunities for AI in healthcare apps, and what are the implications for digital health assessment? We need to understand the risks. Apps are terrible. In the sea of apps that you'll find on the internet, most of them are useless. And there's an organization that's based in the UK, the Organization for Review and Care of Health Apps, that's put together guidelines and does branding assessment for apps. This has been extended by the Mental Health Commission of Canada, work we're doing together where they have an assessment framework structure. And this list of 8 items there, overview of the app, data and privacy standards, how's the app handling it, clinical evidence standards, clinical safety standards, is it user-friendly and accessible? Is it technically secure? Does it work properly? Is it culturally safe? Is it socially responsible? Is there bias in there? Does it conform to equity standards? And then the big question, who owns the data? In many jurisdictions, patients own the data, but the system thinks they don't. There's a huge amount of confusion, even among officials there. I would be remiss if I didn't mention my friend and colleague John Torres, who's at the end of the publication line there. John at Harvard has been doing a lot of work in this area. John and I differ. John believes that it's not good to work with the private sector. I think given the massive infrastructure that has been put out there, how could we not work with the private sector? And there's a worry about what industry will do, but we all negotiate with industry. So this is a thorny piece. They have put together MindLamp. It's a great website to look at, and they're doing navigation around apps, and they have a digital clinic at his lab in Harvard where they actually see patients digitally and manage them for mental health. So, current system issues. Insufficient access to mental health care assessment and intervention is universal. We do not have enough trained healthcare professionals and not enough funded support, and I suggest that we never will. We were talking to governments in Canada for the eMental Health International Collaborative, and we had these workshops which were based on recruitment and retention of health professionals. And at the end of the day, they realized this was the wrong way to go. Work with the health professionals you've got and try and add digital solutions and make it work together. Digital technology does offer a solution, and AI is implemented more widely than you can imagine. COVID pushed us over the edge in 2021, but we've gone too quickly, and we need to evaluate and refine things as we go. Big problems, data solutions. Who can access appropriate data? data standardization. There are all kinds of AI rules coming out in general, and the countries that are putting the rules together do not really see what's happening. They're working with a very fast-moving system, and I worry about them not getting it right. I really believe streaming data and patient ownership is the way to go. Then everybody has their own decision to make. What can AI do in mental health care context? It can lead to transformative change. How can we do this? Everyone wants to do AI. You all can. You just have to collaborate with the right people. It takes a village with different skills. It's like a good neuroimaging team. Some people know the brain, some people know the neuropsychology, and other people know how to do the imaging analysis. It takes a real team. What are the disadvantages? Cultural challenges. We are all biased, and we're all going to have to face our cultural challenges. Don't want to do digital? COVID made you do digital. Now you do digital. It's not too bad. Other forces will push you into digital. Try and figure it out so you can be part of the solution and have a voice and be really active then. Is it really worth making AI a priority? Yes, because of access and equity, if nothing else. And that's it. Thank you very much for listening today.